everyone. Thank you for joining us today. I know it's a beautiful day, so we've got a bit of rivalry. So thank you for being here and grabbing your snacks. We've got a wonderful session planned for you today. My name is Sharon J. We're going to be talking about implementing amyloid targeting treatment for early Alzheimer's disease and the strategies specifically for implementing it and those real-world challenges. You know me, Sharon J. I'm at Stanford University. We've got some wonderful, amazing specialists here with you. We've got Steve Salloway on video, Dr. Ali Atra from Banner Sun Health, and Professor Nick Fox from University College London. This is such an amazing group. I want to first off thank PeerView for providing this session and Eli Lilly for providing the grant for this workshop. Now I want you to look out for polling during the presentation. You'll be submitting questions and we will be answering them through the question and answer session. And you can also visit pace-alz.com for more resources. If you scan this QR code, you'll get access to sessions like this that have been uploaded for the past couple years. You'll also get practice aids and you can listen to podcasts. So you can scan this QR code and get access to all of this information. So visit us at peerview.com/AD25 and then you can get those slides and practice aids. So we're going to start off with the first polling question. Which of the following is the greatest barrier or challenge to implementing amyloid targeting therapies for early Alzheimer's disease? Is it the interest or willingness of clinicians to treat the patients? Is it the patient workup required to select the right patients for treatment? Is it the ability to guide patients about the risks and benefits based on their medical and genetic profile? Is it the resources and workflows needed to deliver this therapy and monitor for the side effects, including ARIA? Is it the availability or reimbursement or the regulatory status where you're from? Or is it all of the above? So take a moment there. Wonderful. All right. So, we're still getting some comments. All right. So it looks like the majority here say all of the above. And then second best answer is the availability, reimbursement, and regulatory status. And then coming in third, resources and workflows needed to deliver these therapies. And then the final few are the guiding patients, the workup required, and the interest or willingness. So we'll get into some of that during the conversation today as well. So our goals for today are to equip you with the strategies to manage the clinical and administrative needs associated with these therapies. We'll improve your ability to monitor the safety and effectiveness of these amyloid targeting therapies in individuals with early symptomatic Alzheimer's disease using evidence-based protocols. We want to augment the capacity to collaborate with multidisciplinary care teams in the management of AD in your specific institutions. We'll talk a little bit about our personal experience too, and I think that can be very helpful for all of us. And then we'll reflect on the learnings from other workshops similar to these, specifically held at AAIC in Philadelphia last summer, and assess how these practical strategies are evolving over time, so that can help you and all of us. So, despite these significant advances in the diagnostic testing and the therapies available, there's still many gaps that persist. So the underdiagnosis, because we want to get to people when they're early in the symptomatic stages, really contributes to some of these gaps. These underutilization of the biomarker testing that we have available. And that can be so many different aspects of it, whether it's reimbursement, availability, really having that conversation with patients and families. And then the healthcare systems may not be prepared to provide that timely diagnosis, whether it's access or other aspects of it. So we have an amazing group here today, and I'm going to pass this off to Dr. Atri to take us through our next steps.
Great. Thanks, Sharon. Very privileged to be here with you and Nick and Steve. And again, thank you for sponsoring this and PeerView. So we're going to talk a little bit about, conversationally, about amyloid targeting therapies. And I think one of the things that's really exciting, and you'll hear some of the things that I said yesterday repeated, I think we're at the end of the beginning in many ways. So this is a completely new paradigm for us as far as both diagnosis and treatments. It's exciting, but we've got probably another decade or two at least of learnings of what to do. And so we shouldn't oversell it, but at the same time, it's important that we make the investments and give the patients and families the power to make their own decisions, right? So as far as the new drugs that we have, it's not all about giving drugs, it's actually about elevating care. So, and I think, Nick, you know, hopefully you can talk a little bit about that.
Yeah. So, I mean, clearly, I mean, I agree. I think it's very easy to forget how long it has taken to get here. This has been a really long journey when we've been desperately seeking something that will slow disease rather than just be symptomatic. So I think that's a great step forward. But of course, this won't cover everybody. This will, but my hope is that we change the paradigm, we change the nihilism, so that while we have effective therapies, which may be just for the few, the many will benefit from better diagnosis, better support, and we've seen that in other diseases. So I think we can really remove some of that nihilism and start making, bluntly, systems that were not fit for what we would want for our relatives to get a timely diagnosis and the support they need. And maybe this will help. I hope it will.
Yeah, I agree. It's not just about these first generation of our disease-modifying drugs that have disease-modifying properties. It doesn't preclude that people can get symptomatic medicines or care in other ways, or just have the choice to decide what they want to do, whether they want to go in a clinical trial. So it's not, they shouldn't be pitted against each other. I think that's really, really important. It's not a zero-sum game. As far as, you know, these drugs having disease-modifying properties, this is not my definition. It's basically, in medicine, it's a definition of something, you know, a therapeutic or drug that works in the pathobiology, does something. In this case, it's a core, you know, element of AD that may be necessary but not sufficient. In the symptomatic stages, you know, potentially with other factors, maybe it's a driver still. So it lowers amyloid, number one. Number two, again, the data are from groups, and from groups, what we can see is that it's slowing decline. So 20 to 40% now. And then we're seeing some signals on downstream biomarkers. So it seems like there's disease-modifying properties. And then as far as, you know, the meaningfulness of these drugs, you know, you mentioned, you know, other fields. I remember, again, being, you know, end of medical school, early training in medicine and neurology, and the MS drugs that were coming along, and being told that, oh, well, they only do something to the MRI, a biomarker. Oh, they're doing very little to change functional decline. You know, even I think the second generation was about 20%. And then fast forward, they've got, you know, 13, 14, 15 drugs. And you can see in relapsing remitting MS, now the relapse rates are 0.1 on average per year. So much so that they have to design different kinds of trials to look at efficacy. And early on, they also had side effects. Same thing for, you know, blood thinners and clot busters.
Yeah, absolutely. And again, that sort of speaks to changing the whole system, not just a new therapy. I mean, I think stroke care has been transformed by having therapies. And we have seen previously untreatable, incurable diseases where once you start having therapies that are effective, you do make it sort of almost change how people think about the importance of diagnosis. I feel like we've historically there was great shame to be slow in making a diagnosis of cancer, but none in dementia. And in some ways, it's almost the opposite. Well, don't rush to make a diagnosis. It might be acute confusion. Will we necessarily be helping anyway? I hope we change all that. And your point about that slowing of that clinical decline, we've changed pathology for many years. We've removed amyloid, but the real change is, and that fits with your diagnosis of disease modifying, we've changed the underlying pathology of the disease, and that has delivered benefit in terms of slowing decline. And we talked before about and I've heard you say it before about none of our patients ever say, is my CDR sum of boxes up by 0.45 or up by whatever, or down by less. But I think in terms of the conversations that we all need to have with patients, it's much more understandable to say, well, on average, this may save you 5, 6, 7 months over that 18-month period. And that's all we can tell you now. And certainly my conversations with my patients, and I don't know what both of you feel, what people really tell me, and this is not just my patients, my mother-in-law, who's cognitively fine, also said, what really matters to me is that I don't want to be a burden on somebody. And all the cognitive scales in the world, that's one thing, but that's what really matters. So we've got therapies that I think are addressing this disease at the stage when people want it addressed. It's not, and I wouldn't want my therapy when I was bedbound and mute. It's when people can still feel like they can maintain independence, that they have the most to gain and really want to stay longer in that state. Now, ideally, we'd like not just to slow disease by 20, 30%, but we'd like more than that. But it's a start, and it is something to be celebrated, and it's at the right stage. So maybe we'll go even earlier.
It's a stepping stone. I think that's really, really important to sort of keep that perspective, and it may not be for everybody. So yeah, I agree with you. I think people want to maintain their personhood. They don't want to be dependent and be a burden on people. And when you see donanemab, lecanemab, they're different antibodies. They work in different ways, but both of them show at 18 months that 80-something% of persons that came into those trials, in the pivotal trials, you can clear amyloid. Not everybody, actually, but 80-something% have amyloid cleared by the end of that time. And the group averages, again, suggest that you get the signal that something is occurring. Now, we're not smart enough yet and don't have the personalized medicine knowledge yet to know who all is getting the benefit more, who's getting the side effects more, and that didn't happen for MS or stroke, vascular neurology in 1 year. It took a long time for that to actually translate and for people to learn. Any other thoughts on that, Sharon?
Yeah, both of you talking really gave me a lot of thoughts about this. Dovetailing on what you were saying, Nick, is just that it's a really exciting time, and it's a very sort of a rapid development in a lot of biomarkers and diagnostic tests available in the past couple years even. So it's really trending for helping us as providers give that diagnosis and have these discussions, very specific discussions. Of course, we want to be a little bit more personalized, and that'll come, but really having these discussions with patients and families about what they want their care to be. And I think that's important. So as much as our own personal beliefs may be, hey, this is disease modifying, this is right for you, or I'm not sure about the safety and the risk benefit for you. Our job is to really educate them with those risks and benefits and see what their personal interests are. Is it to say, I'm going to spend more time with my family, my grandkids, and if this buys me that time, then I really want to take that risk. Or for some people that say, again, we're compared a lot to oncology and sort of those chemotherapies, it's an undertaking. So do they want to spend that time in the infusion center getting these MRIs, et cetera? It really is that patient and family decision with us giving them that guidance.
I agree, and I think there is a fair bit of, unfortunately, paternalism that says that, oh gosh, we get to decide that the risk is too much here. No, the patients should get to decide. They should have an informed choice of what they want to do, and this is not a choice for everybody. But they should be able to do it and be empowered to have the autonomy and for us to provide the justice for everybody, not just select few who can afford it, for example. And yeah, so there's different ways of translating that, whether it's time over that 18 months or a third less chance of going to the next stage of dementia. That again is pretty consistent, whether it's donanemab or lecanemab. You see very consistent results, 20 to 40% consistently in cognition, function, in between, whether it's the iDRS or the CDR. And also, going to the next stage of dementia, going from MCI to mild dementia, for example, I think about 30-something% less risk during that 18-month period, or going from mild dementia to moderate dementia. The drugs are a bit different. They're both infusions at this time. As you can see, donanemab every 4 weeks. The clinical trials, had different entry criteria. Donanemab had a different sort of paradigm where you sort of, rinse the plaques and then you kind of stopped. Every 4 weeks. And then more recently, I think we'll talk about this, Nick. I want to hear your perspective about the modified titration. But there's a modified titration that can potentially affect actually the rate of ARIA. Both of them can have ARIA and infusion reactions. Lecanemab every 2-week infusions. But then in the U.S., recently approved that at 18 months, people can be switched to the monthly every 4 weeks. And then ultimately, I think there are plans in the works for a sub-Q to come along too. So donanemab can be, oftentimes, stopped after plaque clearance. Both of them have infusion reactions. We'll talk about those. Generally, those are manageable. We tell patients as part of the risk-benefit calculus that that's it. Occasionally, they can be a bit more on the severe side, but you can, watch people like hawks and pre-treat them in some cases. We've given people oral steroids even before, or we give, IV steroids during the infusion. And then this sort of gives you the ARIA rates versus placebo in the clinical trials themselves. I'll let you look at them, but they both have ARIA. They can't be directly, again, compared because the paradigms are different. But one thing I think that you saw for both trials was that within the context of the clinical trials, when you had surveillance MRIs and you had very good monitoring of patients and families, you saw in most of ARIA. ARIA is not a symptom. ARIA is an imaging finding, right? And the imaging findings were, as you can see, were found in a certain amount of people, but only, with that monitoring schedule, only about 25%, whether it was with donanemab or lecanemab, had symptoms. And when they had symptoms, it wasn't that severe. Occasionally, it could be severe, and there were even deaths.
Yeah, absolutely. I think it's very important as part of that conversation, where we say, well, look, this is not a cure. And there is burden. There are side effects you need to be aware of, as you said. But that bit about ARIA, which can worry people, and rightly so, about 80% will not be symptomatic. And actually, I think people are more concerned about symptoms than an MRI. Dare I say it as somebody who's been quite keen on MRIs.
Right. But the important thing is to explain that they weren't having symptoms because there was a surveillance and people had to communicate. And, so that's the part that's important. You don't want someone who has ARIA for them to be unrecognized and then for them to continue to get infused in a certain way. So that part of it is really, really important. And but the other part that's important is it can be done. It was done. It was managed in clinical trials, and it can be done in clinical care. But it does require really this concerted effort. All right. Let's see what else. Do you want to talk about this titration?
Yeah. So I think again, we don't have the experience here in Europe that you have in the States, but I've got some experience with some of my patients being in trials, and we can't ignore the fact that there is a burden of having regular infusions, and there are worries about side effects. But I think, as we've seen with other therapies, things will change, and we will find systems that make things less burdensome and reduce risk, and will evolve. This is the beginning, and I think this is a great example of a small adjustment that makes a difference to risk. So just by this titration, which instead of the standard, which you can see the protocol there of 700 mg or 2 vials, 3 times, and then going up to 1400, just by going up at a single step each time, but getting to the same place at the same time, over the same period, made a big difference. So you can see, I mean, the key figure I always think is, and again, it's very, very consistent, this 80% asymptomatic. But if you just look at the headline figures, in the standard dose was about 24%, which fitted with the big phase 3 trials, and the modified titration takes it down. This 13.7 is the percentage at about 6 months. At 12 months, because the paper came out only yesterday, and it's about 15.7%, that sort of level. So a big improvement on the 24%, and that translates into a reduction, as you can see there, from about 5% symptomatic to about 3%. And that does make a difference, I think.
Particularly in the homozygous, I think that was something that would have been a concern. So I think this modified titration is also the appropriate use recommendations for donanemab also came out last Thursday on JPAD. And, so there was also, our group discussed it and thought that this was actually a reasonable option for people to consider. Looking through the slides ahead of this, I was thinking that a takeaway message is how things evolve, whether it's about conversations with patients, we learn from that. But, I was surprised that so soon after the pivotal trials, we've got something that says, okay, we can reduce ARIA in at least one of the therapies. And I hope that'll be the beginning of many other things, reducing burden.
And I think that it's important to recognize, as much as we're having this conversation based on recently published data, things are evolving so quickly, so that when donanemab became approved in the US, we saw the modified titration that came out several months later presented, we were thinking about at our center, should we implement this? Even though it hasn't been officially approved, we haven't seen the paper published, but it really minimizes risk. So we'll see that things are consistently evolving, and we need to think about how we have that discussion with patients and families and see, is it better, is it safer? That sort of thing. Yeah, and being humble and transparent about all the things that we don't know, some of the things we have group data for, and laying it out there with patients' family. It takes time. It takes time, and we have to bring people's knowledge up and their appreciation up. But it is a big decision to go on these drugs, and I think if done correctly, you can be confident that that's something that people, want. And in our case, we also go through this informed consent process, as I mentioned yesterday, and we actually have a consent that is signed that goes into the chart. We talk about the MRI schedules that are a little bit different for lecanemab, donanemab. Usually, getting the baseline MRI within a year, ideally within 3 to 4 months if you can. I mentioned yesterday that Cogswell, Patrice is the first author in a paper with Tammy Benzinger as the last author, American Society for Neuroradiology. They lay out a really nice pyramid as far as, having MRIs on the same platform, if you can 3T, having SWI, maybe gradient echo, both of them, to look at, to compare the sensitivity to specificity, of course, of flare. And then in the appropriate use recommendations, we also suggest considering, particularly if people have had ARIA or they're homozygous, having that late MRI also around, about 12 months or so. I won't lie, it's a heavy lift. It's a heavy lift to do this. Our systems are not as prepared, but it's an initial investment. It's that fixed cost that we have to pay in the field to do all these things. And it's not like somebody's coming up with a tranche of money that said, hey, Ali, Banner's giving you a tranche of money to set this up, right? Banner's in 7 states. We have 30 medical centers. So we had to roll this out as a care pathway. First of all, in very phased and staged ways. And we had to go to the EHR and build out templates for admissions, for the MRIs, for the infusion centers, how to communicate with each other, what's the process. And we limited it initially to now to just the Alzheimer's centers that we have in Tucson, Phoenix, and Sun City. We have a quality review board, we call it. We sit together and we decide together to look at the patients. So there is that, and I know that you do the same, and I'm sure Steve does something very similar. Yeah, I mean, and we'll get into this a little bit later, but essentially all of that, right? It really takes someone motivated and to get, I guess, the follow through in terms of the investment. for all of this, to understand this is important for our patients and their families as things develop, and the communication with our neuroradiology partners for building those MRI sets, order sets, with our infusion partners about those order sets too, and having those double checks in place. And we have a consensus review, that's our name for it, that's similar to a tumor board, to review the cases and ensure that we're all making the decision that is for the best of the patient.
Yeah, so we decided that the care pathway that again had to be, had to go through all these consensus committees, not just pharmacy, but imaging and neuroscience, and got rolled out. And basically, we built out pathways for neuroradiology, how to read what has to be in the report. We set out those templates. We had meetings with the infusion centers. We call people before their infusions, so we have one of our staff, clinical staff, call and review a checklist. At the infusion, there's also a checklist, but we can't put it on the infusion centers and banner to know exactly, We want to make sure if there's any medicine changes, things like that. This is, for example, from Mike Rosenblum, and this is an EHR-based tool, I think through Epic. And you can see, like, even in the beginning, what labs to order, what tests to do, and then how to stage. So, now, for example, we use this thing called Cerner, and when we put the orders in, it's yoked with the MRIs. And if the MRI isn't done at a certain stage and read, and it's in there as a go-ahead, the infusion center will not infuse. And so all these checks and balances have to be done. And we didn't have this in clinical care before. We had to build all this stuff out. It's also important that we learn this stuff over years. And so we have in the US, AllsNet, for example. It's a real-world registry that we're trying to develop to learn what happens in the real world. And I know in different countries there are other registries. We provide things like wallet cards to patients. So if they go to the emergency department, in our EHR, there's actually an alert that comes up that says this patient is on this monoclonal, call this number, do this type of MRI. Careful, a stroke could be a mimic, and clot busters can be contraindicated. So there's a fair bit of lifting to do, but it's manageable, it can be done. It just really requires some thoughtfulness and rigor. All right, Steve's going to tell us all about ARIA and ARIA cases. So Steve, I know this is a great presentation, so please take it away.
Okay, guten Morgen, hola, shalom. Can you guys hear me okay? Okay, good. And hi, Sharon, Nick, and Ali. Good to be with you. Thank you, PeerView, for the invitation. I'm sorry I can't be with you in person. You've heard great remarks already so far from the faculty. And by way of disclosure, I've been involved in testing amyloid-lowering antibodies for many years as a site PI and as a safety monitor and also as a consultant. And Ali and I and others have recently published the appropriate use recommendations for donanemab and previously lecanemab and aducanumab. So I agree with my colleagues that this amyloid-lowering treatments represent an important advance for our field. It moves us into the molecular era of diagnosis and treatment, and it's the beginning, and we're really excited about it. The goal is really to roll these out safely and always put the welfare of the patient first and foremost. If we keep that in mind, we're going to be guided in the right direction. ARIA usually is transient and asymptomatic, but as you know, it can be more serious and even life-threatening. And so we really need to take care to avoid those more serious. It's really not ARIA per se, because most ARIA is really quite benign and manageable. It's really serious ARIA that we want to mitigate. So ARIA comes in two forms, edema, ARIA-E, ARIA-H, hemorrhagic change. Both are really due to leakiness in the vascular tree caused by underlying CAA primarily, with the antibody binding to the vascular amyloid and opening up, making the vascular wall more porous. In some patients, there's a tendency toward a more inflammatory response when there's that amyloid antibody interaction, and that can be quite significant. And it resembles CAA-RI or CAA-related inflammation, and those are the serious cases with significant edema and sometimes serious hemorrhage. But there are steps that we can take to mitigate that risk. First of all, it's identifying the appropriate patient. So I think it's our responsibility as clinicians to determine, is the patient an appropriate candidate? Do they have the right disease stage? Are there safety concerns that really pose too serious a risk for them? And then once we've determined that they are an appropriate candidate, then as Sharon and others have said, then we engage in a conversation with them, with the patient and the family, in deciding whether or not that's something that they want to undertake, because it could be beneficial to them, and the risk-benefit profile appears to be favorable. Usually, as Nick mentioned, there are no symptoms, but symptoms can occur, and typically they're quite mild and nonspecific. Headache is the most common, confusion, dizziness, nausea, unsteadiness, visual change, but there can be seizures, there can be encephalopathy. So you want to, and sometimes it's hard to distinguish from underlying Alzheimer's disease. So you want to determine, how serious are the symptoms and what the course of action should be. It's important to be familiar with the rating scale for ARIA. It's rated as mild, moderate, and severe in the prescribing information. And we make treatment decisions based on this. And so here's just a good scheme here for understanding this. If the edema is small, less than 5 centimeters, and one location, we consider that mild. If it's more than one location and between 5 and 10 centimeters and greatest length, we consider that moderate. And then greater than 10 centimeters is considered severe. Many cases, the more serious cases, are moderate to severe. They may not meet the full criteria for severe, but to your eye, to the clinical eye, they will appear to be severe. And then in terms of microhemorrhages, if there are, so you want to really look at the baseline MRI scan, but an incident microhemorrhages, if they're 4 or less, we consider that mild. 5 to 9 is moderate, more than 10 is severe. And siderosis, that's really important to detect that at baseline, and also incident siderosis, because I think that's more of a marker of underlying CAA and a bleeding or an edema tendency. And so we consider one new area of siderosis as mild, 2 moderate, and more than 2 is severe. But among our expert group for appropriate use recommendations, many of us are concerned about a single incident area of siderosis in terms of whether or not to continue treatment. Ideally, you want to use a high-quality scanner, a 3 Tesla scanner, and the same scanner each time if you can. If there's an emergency situation that may not be possible, the patient may be remote and or traveling at an outside hospital, you may not have access to the images, and so that makes it a little more challenging. You need a good sequence for detecting hemorrhagic change. The studies were based on GRE, but SWI is more sensitive for detecting hemorrhagic change. We use both, and I think many centers also, this is a standard now, SWI, use both sequences and compare them in making treatment decisions. You need the flare for the edema. And then especially if there is an episode of ARIA, you want to get diffusion-weighted imaging to differentiate stroke from ARIA. It's very important. You want to detect ARIA early. You want to keep a mild episode from becoming a more serious episode. And so if the ARIA, the guidance is if the ARIA is asymptomatic and mild, you can consider treating through with ongoing MRI and clinical monitoring. If it's at all symptomatic or radiographically moderate to severe, then you need to suspend treatment, follow with MRI and clinically, and then determine if it's safe to resume treatment once the edema has resolved, which it usually does, and the hemorrhagic change has stabilized. We've given from the appropriate use recommendations based on the phase 3 clinical trials guidance for stopping treatment permanently to avoid a serious outcome, any macro hemorrhage, more than one area of superficial siderosis, more than 10 microhemorrhages, more than 2 episodes of ARIA, severe symptoms of ARIA. All these can really help mitigate a future more serious event. Now, one of the challenges in clinical practice is if the patient becomes symptomatic during treatment, especially early on in treatment when ARIA is most likely to occur, is you have to decide whether or not an urgent MRI is needed and how urgent that should be, and whether or not the patient should be seen in a higher level of care in the emergency room or admitted to the hospital. And a clinical judgment is needed. In our situation, so you need to have somebody on call at all times for your patients while they're on treatment. We have nurse practitioners who help a lot at our center, and so I highly recommend that. And I think you heard about case conferences to review appropriateness and also to monitor for ARIA and manage ARIA. And that can be done in a team environment. So we also have a regular case conference, which is very helpful. So in a symptomatic patient, you have to weigh, whether or do they need a higher level of care, and then there are pluses and minuses. One of the risks of going to the emergency room is that ARIA can present as a stroke mimic, and the patient can get on a stroke pathway and receive thrombolytic treatment pretty easily in our current emergency room care pathway. And that may not be the most appropriate treatment. It could be quite dangerous for the patient. So you really have to help coordinate the care if you do send them to the emergency room. Now, coordinating with the emergency team, so planning ahead is really important. And you can work with your local emergency team, the hospital that you have the most closest association with. But again, sometimes patients have to go out of the area, and you'll have to then interface with another emergency team on behalf of your patient. As Ali said, it's possible to put in the medical record and give the patient a medical card that they're on a thrombolytic, that they're on an amyloid-lowering treatment, that ARIA can mimic a stroke, that thrombolytics are relatively contraindicated unless absolutely necessary. And so if it's very helpful for the emergency team and the stroke team, if they get involved, to know that the patient's on this treatment and what some of the consequences might be from usual care for usual stroke care. ARIA can also present with focal signs and with seizures. And then for cases where it's unclear if it's ARIA or stroke, an urgent MRI or prompt MRI, which is not always easy to get in the emergency room, will help with the diagnosis. CT is really not adequate for detecting ARIA. And then if ARIA is the main etiology of the more serious episode, then that patient will likely require a higher level of care and then empiric treatment with high-dose corticosteroids and treatment of seizures if they're present. So far, I'm aware of 3 cases. One was just published, as you heard yesterday, in the modified titration manuscript of cases that mimicked a stroke, went to the emergency room, received a thrombolytic, and had a fatal outcome. This is one from the New England Journal with lecanemab. There have been 2 with donanemab so far that I'm aware of. this is something that we can do a better job at. So we have to be really it doesn't occur very often, but it can occur. And we have to have heightened awareness about this because we don't want our patient to have a serious outcome when that could have been avoidable. I really want to encourage us, the field and clinicians, to become familiar with emerging. We heard about from Sharon about emerging. Our field is evolving, and one way we're evolving is in AI-based software to detect ARIA, and also to measure changes in PET scans and MRI scan and brain imaging over time. So this type of software, one has been cleared by the FDA. Others are in development. They look really good. And they can really assist the radiologist in doing a standardized read and assist the clinician also in monitoring the ARIA and making treatment decisions. So we want to take advantage of these new tools as they become available. Let me share a couple of cases, practical cases regarding amyloid-lowering treatment. So the first case is Henry, a 68-year-old man with MCI due to AD. He has type 2 diabetes and arthritis. His MRI scan baseline showed 2 lacunar infarcts, 2 smaller infarcts, and mild to moderate small vessel ischemic change. He's an ApoE4 homozygote on metformin, meloxicam, and now donanemab. And he presented to his neurologist for an unscheduled MRI because he was experiencing headache and blurry vision for the past 3 days. Let me just say that most cases of ARIA are detected on the routine safety MRI scans that are pre-scheduled as part of routine care. But occasionally in cases like this, patients become symptomatic. And so he's having blurry vision for the days. He had his 3rd donanemab infusion 7 days ago, and his last safety MRI was normal. And this urgent MRI scan shows change here on the flare sequence in the occipital lobe. You can see inside that yellow circle. And on the GRE SWI, also 2 areas of hypoattenuation in the same area, in the occipital region bilaterally. And the diffusion image is normal. So I think, Sharon, you're...
Yeah, we've got a polling question. Thank you. Yeah. So this is now for you to get on your device. What is the type and severity of this ARIA? 1, I'm not sure. 2, moderate ARIA E. 3, moderate ARIA H. 4, moderate ARIA E and moderate ARIA H. Or 5, severe ARIA. Dramatic music, cue now.
This is where Nick has to sing.
I wonder how they choose.
This is where you have to sing.
Yeah.
Or dance.
And Steve, I'm not sure you can see the responses, so I'll read them to you.
Okay.
54% said moderate ARIA E and moderate ARIA H. Second in 24% was moderate ARIA E, and then 12% say moderate ARIA H. 5% say I'm not sure, and 5% say severe ARIA.
Okay, well, those are good answers. You can see from the MRI scans that the area involved is really not large, but there's more than one area of edema, so it's bilateral edema. So that qualifies as being moderate, even though the areas are small. And then here we have 2 areas of superficial siderosis in the same region, and that would be considered as moderate. So the correct answer is moderate ARIA E and moderate ARIA H. Okay, I think you're doing this one too.
It hasn't turned over to us yet. So let me see if I can. Oh, well, I guess it wasn't a polling question, so we gave you the answer.
Right.
We said,
Well,
what is the next step?
What's the next step in
Yeah.
care? This is important because this case, and this is again, patients in E4 homozygote, so we're concerned about safety. In some parts, Some healthcare systems, they're not permitted to be treated with an amyloid-lowering treatment, but the FDA is more permissive about that. The appropriate use recommendations allows for a discussion, as Ali said, with patients and families about risk and helping them decide what is in their best interest. But for this type of patient, especially with 2 lacuna with cerebrovascular disease, we'd be very concerned about safety. So the 2 areas of, if he just had the REE alone, you could wait till that resolves and then resume treatment. But the 2 areas of superficial siderosis in this case would really qualify for discontinuation by the appropriate use recommendations, and also I think just by good clinical practice to err on the side of safety. Okay, next case is a 70-year-old woman with MCI due to AD. She has COPD. She has no mild white matter changes, no microhemorrhages on her baseline MRI. She's an E4 heterozygote. She's on a bronchodilator and lecanemab. And she's had 4 lecanemab infusions. She comes in today for first routine monitoring monitoring MRI prior to her 5th infusion. She's asymptomatic. And her MRI scan shows this new isolated area of edema on the flare, less than 5 centimeters. So I think.
So now we have a polling question. Yes, thank you. What would you do next? 1, suspend treatment and monitor with monthly MRI until it resolves. 2, continue treatment and monitor with monthly MRI until it resolves. 3, continue treatment and monitor with routine MRI schedule, which is next prior to the next 7th infusion. Or 4, I'm not sure. All right, so the majority, 63%, say continue treatment and monitor with monthly MRI until the ARIA resolves. 20% say suspend treatment and monitor with monthly MRIs until the ARIA resolves. 14% say continue and monitor with a routine MRI monitoring schedule. And 3% say I'm not sure.
Okay, great. Again, good answers. This is, mild asymptomatic REE, and in the clinical trials and in the appropriate use recommendations, it is possible to continue treatment with careful monitoring. I would recommend, with the majority here that we go with the monthly MRI. Right now, things are mild, and we want to make sure they stay mild and resolve quickly. And we don't want this to become more serious or not be aware that it's more serious while we're treating through. So I think that's the safest approach. Some people, this is not an E4 homozygote. This patient is not an E4 homozygote, heterozygote, to increase risk of having ARIA and more serious ARIA. Some people may elect to be more conservative. Let's say the patient was an E4 homozygote and may decide to suspend treatment until the ARIA resolves and then resume treatment. So there's clinical judgment there, but certainly there is guidance that would allow continued treatment. And this is a case from our own practice who did very well. We continued treatment with monthly monitoring. Actually, on the next MRI, the ARIA resolved, and she continued treatment and has continued to do well. And finally, is a case of a 65-year-old man with hyperlipidemia, significant hearing loss. Baseline MRI shows 2 microhemorrhages, moderate white matter changes, and he is homozygous for E4. And he started on an amyloid-lowering treatment, had the 3rd infusion 2 days ago, and now presents with an acute event with confusion and seizure. That's obviously concerning. And he was sent to the emergency room. Okay, and here's his MRI scan.
And we have a polling question. Should I read that, Steve?
Yes, please.
Yeah, it shows that Michael has severe ARIA-E. What would you recommend next? 1, suspend amyloid targeting therapy. 2, suspend. They're the same. So that's a trick question there. Number 3, suspend it and admit to the hospital for observation. 4, suspend it, admit to the hospital, initiate high-dose steroids. 5, suspend, admit, initiate high-dose steroids, and anticonvulsive treatment.
It's a little bit of a trick.
So vote now. There we go. All right, some answers are still rolling in, but essentially the majority, 59%, say the last one. Suspend therapy, admit to the hospital, give steroids, and start anticonvulsive treatment.
Right. So this is sort of a build set of choices here. Yeah, obviously this patient, again, we're very concerned, E4 homozygote, has some baseline CAA on his MRI scan, and now early on in treatment has developed, is quite symptomatic and has very large areas of edema. We're only seeing, one cut here. There's at least one microhemorrhage so far. There's probably going to be many microhemorrhages when you get this much edema. So very concerned about that patient, and we want to differentiate stroke from ARIA and make sure we're treating the right condition. Here he has, this is CAA-RI-like syndrome, resembles CAA-RI, and so it's important to admit this patient to the hospital, making sure getting the right level of care, using empiric high-dose steroids to accelerate the recovery, and treating seizures, which he's already had a seizure. We're going to monitor for seizures. Sometimes in these cases, seizures can be hard to treat. There have been fatal cases of refractory status epilepticus, at least 3 that I'm aware of. And so we want to make sure we're in control of the seizures early on. And so his ARIA symptoms resolved over 6 weeks. The edema resolved over 10 weeks. There were 20 residual microhemorrhages, and that's actually very common after a case like this with severe edema. And so another polling question.
All right. Should the treatment be permanently discontinued, restarted at a lower dose, or I'm not sure? I like that final drama. Permanently discontinued, say 82% of the audience. 13% say restart at a lower dose. Steve.
Okay. Well, yeah. So I think this case is hopefully pretty straightforward. This patient had severe symptomatic ARIA, did well. He survived the episode and recovered. And some patients actually get better because there's often amyloid clearing associated with this. But now he has he's an E4 homozygote, has underlying CAA, is at high risk, had this severe episode. And if he were to be retreated, it'd be concerned that the next episode could be even more serious. So it's very important then to permanently discontinue treatment in this case. So the key takeaways are that we're at a new stage of care for Alzheimer's. I think I want to echo my colleagues' comments. Monoclonal antibodies are the standard of care for many medical conditions, and we can do this in Alzheimer's disease too. Safety monitoring and appropriate management is critical. We want to roll this out safely, and to do that, we need to select the appropriate patients, heed the warning signs, and detect ARIA early and manage it carefully. So thank you. Thanks for listening, and I look forward to more discussion.
We've got a few more minutes left. I'll just mention here the importance of really connecting with the teams at your specific institutions. I don't need to go through this, but essentially we've discussed a bit briefly about how we connect with our colleagues, whether it's pharmacy, radiology, nuclear medicine, infusion, emergency room. We connected with our stroke colleagues too to discuss what their thoughts are, so get everyone on the same page. And despite all of that, things can happen, especially if they don't come back to your institution. I don't know if you guys have any other comments about that. But I think it's just really key to have that
Well,
conversation.
and that whole multidisciplinary approach is, again, hopefully a change that we'll make for the field, which will be better for everybody, not just people in this situation, as has been seen in other areas.
Exactly. Let's see. First question here that we see here, how do we manage people with moderate Alzheimer's disease who are keen to trial the amyloid targeting therapies? What are your thoughts here, Nick?
Well, I think that, yeah, that's one of the things that we haven't been in this position before, of saying to somebody, there is a disease-modifying therapy, but it's not appropriate for you. And those will be difficult conversations, which we will all learn to navigate through. But it's been done in other areas of medicine. It's not indicated for that setting.
Yeah, let me get to another question here. I think this is a topical one because at least in the US, we've had approval of lecanemab in 2023 and the donanemab in 2024. This question is, what's the consensus on continuation of anti-amyloid drugs beyond 18 months? What do you think, Ali?
Well, I think that you need to have, again, that frank discussion with patients and families. For people who, progress to, really later stages, at that point, I think it's important to have a discussion with them if they're, now in the moderate or moderate severe stages, that, we don't, at that point, really have that risk benefit is unknown, whether it's, to continue or not. The stopping rules are not, we haven't figured those out yet. Those are the things that we need to figure out. One of the things, for example, that we're looking at is potentially after 12 or 18 months in the US being able to look at the amyloid again to see if it's cleared, for example. And then in the case of donanemab, there is no maintenance schedule, but for lecanemab there is. So, having those discussions.
Yeah, and I think the point of the question is that, is there consensus? And there isn't a consensus.
No, there
right?
isn't. It's really a bit of a data-free zone, and we need to understand it better. That's why I think registries that follow people can give us information about cognitive and functional changes over time, about safety, and then hopefully we can understand a little bit more about the biomarkers, about who is who maybe is getting a bit more benefit, and in which cases is Alzheimer's the driver of their condition more.
Yeah.
But I would say that again, a patient that let's say is on lecanemab, they're still, in the MCI or mild stages. I think again, there's a paradigm for maintenance, and honestly, we don't know. I mean, I guess it's every monthly, but. I tell people, I say, I don't know for you whether it's going to be monthly or, every 2 months or every 3 months. That's something we have to figure out. So we may start at monthly. Honestly, I haven't got to that point yet with people at 18 months yet.
Nick, any final thoughts from you?
Well, just to say, it's so important that we learn as these, particularly in places like the UK, where the experience. The only silver lining is that we'll learn from other people.
Steve, any final thoughts from you?
Well, I don't know if you can hear me. Can you hear me?
We can hear you.
We can hear you now.
Oh, good. Well, just that comment about the, Ali mentioned about the data-free zone, which is true, about I think it makes sense that there be an initiation phase where we lower amyloid and a maintenance phase that could be beneficial, whether we don't know for sure long term. And we're also at that point where some of our patients are now at 18 months, and we're definitely going to maintenance for lecanemab because there is a schedule there. And we're planning a maintenance for donanemab, and just based on, again, good clinical judgment, probably every 2 months or so, we would lengthen out the dosing because, we don't know for sure, but certainly we've had experience with long-term multi-year treatment with aducanumab. We've had patients who are stable. When we stopped the treatment, all of a sudden they started to decline. And, there could be some ongoing benefit. Now, for the patient, like Ali mentioned, who progresses now to more advanced stages, then we're going to have to address that with the family. They're probably not benefiting anymore. But there are patients who seem to be benefiting, and then they may benefit from maintenance.
Yeah, and I would caution people not to, again, abstract a person to one number, right? Not to their MMSE score, right? You have to do a holistic sort of evaluation to see if they're really in the moderate or moderate to severe stages. So just because they're MMSE at a certain point, that does not represent, moderate dementia. So it requires a holistic approach
But some healthcare systems, like the UK, when I was just visiting with Nick last week or 2 weeks ago, are going to be more restrictive. They actually have a guidance for stopping at 18 months, or if amyloid is lowered, or if they progress. So they have actual rules built in, which we don't have currently in the States. So each healthcare system may be a little different about that.
Yeah, I think depending on the restrictions where you're practicing, but I think it's the importance here is that things are evolving. It's a very exciting time with the developments, but we're still learning. And I think that's your point, Nick, that we're learning from each other. Forums like this, where we can learn how each site and each prescriber, how they're managing. But also that because things are evolving, patients are evolving too. So having those continued discussions about whether you want to be conservative, even though there are guidelines, things may change over time about what we do. So thank you all for being here today.
Thank you. Cheers.